Have you ever thought about how uncomfortable it would be if the food you ate hours ago just stayed in your stomach and never emptied out? Well, this type of stomach problem affects about 5 million people in the United States at any given time. Hello and welcome again to Hope in the Pipeline. I'm Dr. Paul Wiley, neuropsychiatry, sleep medicine, and clinical trial specialist, and the medical director of Preferred Research Partners in Little Rock, Arkansas. In this episode of Hope in the Pipeline, I'm going to focus on a disorder called gastroparesis, which is a fancy medical term for delayed emptying of the stomach contents into the small intestine when there is nothing blocking the movement of food or liquids. I will talk about how volunteering to participate in a local clinical research trial testing a new treatment for gastroparesis might be of benefit to you now and can be a big help allowing other affected people to access better treatments in the future. When someone has gastroparesis, food just sits in the stomach for much longer than normal, usually many hours, which can lead to symptoms of nausea, vomiting, bloating, belching, weight loss, heartburn, prolonged feelings of fullness, and acute stomach pain. In healthy people, when the stomach is functioning normally, contractions of the stomach muscles help crush ingested food and then propel the pulverized food into our small intestine, where further digestion and absorption of nutrients occurs. Normally, more than 60% of a meal should be out of the stomach in around 2 hours. In one group of 28 patients with gastroparesis, 93% of them experienced nausea, 89% reported experiencing abdominal pain, 86% early satiety or sense of fullness, and in 68% there was vomiting. The stomach pain is usually described as burning, vague, or crampy in nature, and only 36% of the time is the pain localized only to the upper abdomen. Women are affected by gastroparesis about 4 times more frequently than men. The average age of onset of gastroparesis is usually in the mid-30s, but the disorder can start at any age. While several medical conditions have been linked to causing gastroparesis, in about 4 out of 10 cases, doctors are unable to determine what caused the gastroparesis to develop. This type is known as idiopathic gastroparesis. Diabetes is the most frequent cause of gastroparesis, producing about 30% of all cases. Diabetes, or too much blood sugar, can damage the nerves that control stomach contractions, such as the main vagus nerve and also the smaller nerves connecting to special pacemaker muscle contraction cells located in the walls of our stomach. As a result of nerve damage, the muscles in the stomach can either work too slowly or their contractions are too weak, and so they are unable to effectively move food from the stomach into the small intestine. People with diabetes often ask, what are the beginning stages of gastroparesis? How do I know if I'm starting to get it? Well, it might start with repeatedly feeling full after eating just a few bites, and still feeling full for a long time after eating a meal. Vomiting of undigested food eaten many hours earlier may occur, sometimes during sleep, resulting in an aspiration pneumonia developing from stomach contents getting down into the lungs. Acid reflux is usually present, and problems may develop with blood sugar swings, resulting in dizziness, fatigue, and nausea. In severe cases, gastroparesis can result in malnutrition from difficulty absorbing essential nutrients from foods. There may be a failure to absorb key ingredients from important medications, and gastroparesis sometimes can cause dehydration severe enough to require hospitalization. In long-term cases, severe gastroparesis can result in the formation of what is called a bezoar. Bezoar is one of my favorite words from medical school and refers to hardened masses of food in the stomach. I saw a bezoar removed in medical school from a patient in a nursing home who had a previous gastrojejunostomy close off after a portion of her stomach and upper small intestine had to be removed from a cancer. The bezoar was the size of and as hard as a golf ball and smelled magnificently horrendous. GI specialty doctors are called gastroenterologists and diagnose gastroparesis based on medical history, a physical exam, symptoms, and through various medical tests. There are several different tests that have been developed to measure the speed and completeness of stomach emptying. A GI specialist may also use medical tests and procedures to look for causes of gastroparesis and complications. Gastroparesis can be a complication that occurs after some types of surgery if the vagus nerve is injured. COVID-19 is a recognized cause of severe gastroparesis. Gastroparesis has been described as a complication of several malignancies, including gastric, pancreatic, gallbladder, esophageal, and lung cancers, as well as leiomyosarcoma, a special type of smooth muscle cancer that can affect the intestines, stomach, bladder, and the blood vessels, as well as the uterus. Sometimes delayed transport lower down in the intestines, for example in the colon, can be the primary problem, say from blockage by a tumor, and gastroparesis can be the secondary problem. In addition, cancer treatments, such as radiation therapy, can also damage the nerves, resulting in gastroparesis. Recently, research published in the Journal of the American Medical Association found an increased risk of gastroparesis in people using GLP-1 drugs like Ozempic and Wegovy, Mounjaro, and Zepbound. According to a May 2024 story in U.S. News & World Report, 10 out of every 10,000, or 0.1% of patients who took GLP-1 drugs for weight loss were subsequently diagnosed with gastroparesis. Let's talk now about the different ways that people are evaluated for gastroparesis. To see how fast your stomach empties, you may be asked to undergo one or more of these tests. Scintigraphy, a test that has for years been one of the main non-clinical trial ways used to diagnose delayed stomach emptying. It involves eating a light meal that has a tiny amount of radioactive material in it, and then a scanner follows the movement of the radioactive food, allowing visualization of the rate at which food leaves the stomach over about 4 hours. In 2021, the FDA approved what is called the Cairn Carbon-13 Spirulina Gastric Emptying Breath Test, which is shortened to GEBT. And GEB is a non-invasive test where the patient consumes a small amount of labeled food and then provides breath samples which are analyzed for their carbon dioxide content. Our clinical trial coordinator, Ms. Jessica Watson, is going to provide more details to you about that particular test in our next podcast segment. Sometimes another motility test is employed that uses a wireless system called the Smart Pill, which is actually a capsule that contains a small electronic device which records information such as stomach pressure, acidity, temperature, and time as it travels through the stomach and upper intestine, and the information is transmitted to a recording device worn on the belt or around the neck. The capsule is eventually passed in the stool a day or two, or even 3 or more days later, depending on how delayed a person's GI tract is in emptying. In some cases, an abdominal ultrasound may be ordered. This test uses high-frequency sound waves to make images of structure within the body and can help diagnose whether problems with the gallbladder or kidneys could be causing gastroparesis symptoms. Sometimes GI specialists need to use an endoscopy camera to look for problems such as an obstruction in the digestive tract. During an endoscopy procedure, the upper portion of the gastrointestinal tract is visualized with a flexible scope that has a camera on the end of it. Jessica will also talk you through the endoscopy test process as well during our next podcast. Gastroparesis is a chronic condition, and in most cases, it does not go away or have a definitive cure. However, its symptoms can be managed, and the progression of the condition can be slowed with appropriate treatment. Here are a few basic treatment tips that might be useful. Alcohol and nicotine should both be avoided since they slow gastric emptying. Exercise has been shown to increase stomach emptying in healthy individuals, and they might improve symptoms. Specifically, consider walking after a meal. Don't lie down for 2 hours after a meal. Eat foods low in fat and low in fiber. High fiber foods can create a blockage in your stomach when you don't have enough water. Examples of high fiber foods that you might want to consider avoiding if you have gastroparesis include raw vegetables, raw fruits, nuts, and seeds. Also, avoiding oranges and broccoli may help. Dairy products should also be avoided because lactose is not easily digestible. Try eating 5 or 6 small nutritious meals a day instead of 2 or 3 larger meals. Chew your food thoroughly and eat a soft, well-cooked meal. Avoid carbonated beverages. Try soups or pureed foods. Take a daily multivitamin. Drink plenty of water, at least 1.5 liters a day. Consider consulting a dietitian about designing you a gastroparesis diet. Some alternative medical techniques have been used to treat gastroparesis, such as acupuncture, including electroacupuncture, where a small electrical current is passed through the needles. Studies have shown that these treatments may ease gastroparesis symptoms more than placebo. Now, I'd like to speak for a while next about medications and medication adjustments that are often used to treat gastroparesis. Often, treatment of gastroparesis begins with better blood glucose control in diabetics. High blood glucose levels slow stomach emptying and worsening symptoms. The use of a class of medications called prokinetics is commonly used for the treatment of delayed stomach emptying. These medications stimulate muscles in the stomach to propel food forward, improving stomach emptying amount and time. An example of a prokinetic medicine would be metoclopramide or Reglan. This medicine increases the muscle movements in your digestive system, helping the food to pass more quickly and efficiently. However, Reglan has an FDA black box warning for the potential to cause a rare but permanent neurological disorder called tardive dyskinesia. And metoclopramide or Reglan can also be a rare cause of loss of control of our internal body temperature. I am pleased to report that the FDA approved a metoclopramide nasal spray called Gimoti, Gimoti, made by Evoke Pharmaceuticals, for treating the diabetic type of gastroparesis, and this nasal form of the drug has less potential to cause side effects than the pill form, but still the possibility remains. Unfortunately, metoclopramide or Reglan is the only medication in the United States that is FDA approved today to treat gastroparesis, and that is exactly why the efforts of preferred research partners, working with pharmaceutical companies, and partnering with volunteers to perform clinical trials is so important to the development of safer, more effective treatments with fewer and less severe potential side effects. Sometimes the use of antiemetics or anti-nausea medications, such as Zofran or Compro or Vistaril, can be helpful with the nausea and vomiting caused by gastroparesis. But these meds don't improve the rate of stomach emptying, and they have sedation and actually can cause more GI motility side effects. Perhaps even more important than being on a medication to help with delayed stomach emptying symptoms is being off medications that might be worsening or causing the gastroparesis. For example, Imodium, narcotic pain medications, oxybutynin, tricyclic antidepressants, and calcium channel blockers such as verapamil, amlodipine, and nifedipine. Clonidine, lithium, and dopamine agonists such as Mirapex used to treat Parkinson's disease can also cause gastroparesis to develop. Nicotine also slows gastric emptying. Marijuana has also been shown consistently to slow gastric motility based on research performed using the cannabis analog called dronabinol. There is a medication called domperidone, which has been around for years, that can really help with the symptoms of gastroparesis in some patients. However, there are some concerns that domperidone can cause some heart rhythm problems, such as prolonged QT interval in susceptible patients. I know some patients that swear by the benefit of this medication that used to access it from pharmacies in Canada, but recent tariffs and other laws have made that process difficult. Currently, the FDA doesn't approve the use of this medication except when other treatments have failed. And to prescribe the medication domperidone, healthcare professionals must apply to the FDA for what is called expanded use access. One new medication in development by Allergan Pharmaceuticals is called Relamorelin. The results of a phase 2 trial found that this drug, which is a ghrelin receptor agonist, shows potential for speeding up gastric emptying and easing vomiting. Ghrelin is an appetite-stimulating hormone found in the walls of our stomach. The FDA has not yet approved this medicine for use, and so study of the drug is ongoing for gastroparesis and several conditions, including diabetes, Parkinson's disease, and chronic constipation. The compound seems to speed up gastric emptying by 15 to 30 minutes, depending on the type of gastroparesis someone has, and so it holds some promise. This is yet another example of the importance of all of us volunteering to be in a clinical trial to help test new treatments. Now, let's shift topics a bit because some people have asked if there are any surgical procedures to treat delayed stomach emptying. Some people with severe forms of gastroparesis may be unable to ingest any food or liquids through their mouth into their stomach. These folks may benefit from the use of a feeding tube called a jejunostomy tube being placed in the small intestine to bypass the problem stomach area. Some patients require the use of what is called a gastric venting tube to help relieve pressure from gastric contents. There is a surgical procedure known as endoscopic pyloric myotomy, also called gastric peroral endoscopic myotomy, or GPOEM, G-POEM, which involves making a cut in the muscular ring between the stomach and small intestine. This muscular ring is called the pylorus. This procedure opens a channel from the stomach through the pylorus into the small intestine and is currently being studied in some clinical trials. Some patients with diabetic gastroparesis may benefit from implantation of an electrical stimulator. In gastroesophageal stimulation, a device is implanted under the skin in the abdomen wall that sends electrical impulses to the stomach muscles, stimulating those muscles to contract and push food into the small intestine. I am pleased to report that at Preferred Research Partners, we are currently privileged to once again serve as a site for a pharmaceutical company to test a new medication for the treatment of acute and recurrent gastroparesis. We previously did a study for treatment of diabetic gastroparesis with this same new medication, but this time the study medication is being tested specifically for effectiveness in idiopathic gastroparesis, that is, gastroparesis with no identifiable cause. The principal investigators for the study are experienced Little Rock gastroenterologists Dr. John Baber and Dr. Dan Brown, who you can make appointment with by calling the St. Vincent Infirmary GI Outpatient Clinic at 501-666-0249. We are currently looking for individuals aged 18 years and up who have already been diagnosed with gastroparesis or who think that they might have delayed stomach emptying to help further test the effectiveness and safety of this new medication. So, if you or a loved one or a friend knows someone who has or might have gastroparesis and think that they might be interested in exploring the possibility of joining this clinical trial, please check out our website or direct them to our website address at www.preferredresearchpartners.com to learn more about this study. I'd like to request that you please like, rate, and review our podcast, which helps more people to find it and to learn from the content. If you know someone who you think might benefit from viewing this podcast episode, please share it with them. As always, thanks so much for listening to today's podcast, and having done so, I anticipate that if you have been affected by problems with delayed stomach emptying, you should now be more aware that there is hope for your pipeline. We'll see you again next time when I invite Coordinator Jessica Watson to be my guest on the show, and she will introduce herself and take us through the process of the experience of being an interested volunteer participant in a GI clinical trial from start to finish, in particular, this gastroparesis trial. Until next time, stay safe and stay healthy.